I'll see if I can do this. Okay, let me do it this way instead and see if that makes it easier. Okay, has that come up for you guys?
No.
No, okay, let me just come back. Okay, so hopefully we're there now. Hang on, I'm also working across 2 screens, which adds and added.
And thanks for those who have put a question in the box already. I am sure some of this information is going to be covered. So let's see what the slides say and what Nicola says, and then start popping your questions in as we go along, and I'll read them out to Nicola at the end. Thanks so much.
Okay, so welcome. So as I said, so the purpose of today is to talk about ARFID. So as you may or may not be aware of, those of you on the call, so ARFID stands for Avoidant Restrictive Food Intake Disorder. So although we kind of think of ARFID as a new diagnostic term, it's actually been around in the DSM-5 since 2013, so over 10 years now. But in my experience, it feels like it's only really been the last few years, kind of 2 or 3 years, that services have been more aware of ARFID and that services are being asked to deliver support around ARFID. Certainly within our service, I think we've had a pathway within the team for about 3 years. And I would say that we've become a lot more, we've kind of fine-tuned that pathway a lot more probably within the last year. So what is ARFID? So ARFID is a feeding and eating disorder. It's something which has always been around, but it might have been termed something differently, for example, like a pediatric feeding disorder, or something similar. So it's a term for different feeding disorders that's now been brought together. In terms of the diagnostic eligibility, so to be diagnosed with ARFID, you need to meet one of the following criteria. So to have a significant weight loss or faltering growth or development, or a significant nutritional deficiency, or a dependence on enteral feeding or oral supplements, or a marked interference with psychosocial function. So that's the kinds of things that we're looking at when we assess young people within CAMHS. And then, so we've got the diagnostic eligibility, and then secondary to that, we've got our drivers. So we would talk about what's driving that food and eating behaviour. So we've got sensory sensitivity, which is where a young person might really struggle with different brands of foods, tastes, textures, smells. They may find it easier to only eat one particular type of food, for example. Lack of interest, which is for a young person that might be just not driven by food at all. It's just not something, it's not something that they enjoy. It's not something that they kind of think about. They wouldn't think to eat unless they were prompted to do so. And then lastly, fear of aversive consequences. So this is where this is slightly different to what we might consider in the other two drivers, so sensory sensitivity, in that a fear of aversive consequences is that something, a child or young person is particularly worried because something bad is going to happen to them because they've eaten that food. That might be choking, that might be vomiting, it might be because of an experience they've had at some point that's been traumatic, that's found that means that they now find that really tough. So that might be around a particular food, that might be around lots of food. So we might see young people that come into us that find it really difficult to eat solid food, and maybe they've been on more of a liquid diet because of a choking episode, for example. So young people that are autistic can also have a diagnosis of ARFID. As I'm sure you can imagine, there's quite a high comorbidity between autism and ARFID. I guess what's important to say is that where we might think of giving a diagnosis of ARFID instead of autism would be where a young person that's autistic also has a nutritional deficiency, or their weight is impacted, their physical health is impacted. That is because with autism, we expect some challenges associated with food and eating. So we expect there to be some sensory sensitivities. We expect that the social environment around eating is going to be a bit more challenging. So what we need to think about is actually what's in the context of that and what's different or over and above. So ARFID is really different to picky and fussy eating. So all of us that are on the call today will all have preferences and dislikes about food and about drinks, and that's absolutely normal and appropriate. And children or adults will often eat more or less in response to when they feel worried or they're upset or angry or overwhelmed. We all might do that. Where ARFID is different is it's a pervasive and a chronic difficulty which can cause a significant impact on health, development and functioning in everyday life. And we would expect to see that difficulty across all areas of that young person's life. So, you know, it's not just that eating at school is difficult, but eating at home is okay. We would expect that there's challenges across everything that they do. So these are some of the signs and symptoms. So these are things that we might look for. So in terms of weight, with a diagnosis like ARFID, they quite often we do see young people that are underweight, but we also see young people that are of an average weight or overweight. Generally, they're really an extremely limited selection of food. So, you know, at kind of the more extreme end of the spectrum, it might be, you know, 5 or less foods. It might only be certain brands, or they may stop eating altogether. So there might be this, what we would think of as acute food refusal. Generally, there's an impact on family functioning and dynamics. So normally, you know, it's really difficult to eat all together as a family because the child that has ARFID just finds that environment really difficult, or they can't be around other people when they're eating because of the smells or the views of other people's food. Young people with ARFID often present very young. So we see young people in the team from age 5 and above. And I would say that in terms of our referral numbers, we probably see young people that are kind of between age, the majority of our numbers are probably young people that are between kind of 5 and 10 years old. They may rarely appear to be hungry or ask for food. So if we think about that lack of interest driver, that's, you know, it's just not something that's coming into their conscious to think about. Avoid to sit down or perhaps needing some distraction to eat. So quite often we see young people that need to watch something on YouTube or need to be able to play a game or do something while they're eating because it's difficult. It's difficult for them to have their full focus on the meal. They may gag or vomit when they attempt to eat, and that could be when they're trying to eat something new. And generally, there's a really high anxiety over any new food. So being completely unable to try new food, and that causing some real significant problems when that's requested by somebody. In terms of causes and risk factors, so like any of these diagnoses, there's not a single cause. These are some of the things that we might think of as a risk factor. So, for example, premature birth or complex medical issues in early life, early feeding difficulties, so difficulties with latching on in breastfeeding, difficulties with moving from maybe being breastfed to bottle fed, challenging when you go through the weaning process, vomiting or gastric reflux as an infant, severe constipation or eczema or food allergies, a later introduction of solid foods. Likewise, sometimes an earlier introduction of solid foods is difficult. Generally, there could be challenges around developmental difficulties or delay. Normally, there's a general dislike of change or anything new. And there can be some anxiety within the family. So anxiety around food, anxiety around eating, which could also be a risk factor. So if you're concerned that a young person may have ARFID, it's important, if you can, to have a conversation with them or their primary caregiver. Seek consent to share with relevant people, so whether that's your GP, whether that's us at CAMHS. You can also seek consultation and advice from us, so having a phone call with discussion. Obviously, there's events like this, but we also go to the PACE events, so the parent and carer events across the county. So there's one of those every month, which has different talks as well. So we do a talk around eating disorders, and there's lots of other talks from CAMHS too. It's really important, and we hold this in mind a lot, to consider any safeguarding concerns. So, you know, the eating difficulties that we're seeing, are they caused by challenges around actually accessing food or difficulties with boundaries or expectations at home? Sometimes that can come into the picture as well. So we spend a lot of time kind of really thinking about what's the driving factor, what's the formulation around a child's difficulties with eating. In terms of our assessment, so we do quite a lot now in a pre-assessment. The reason for that is for an ARFID diagnosis, we recognise that we need lots of information. We need to understand a lot more what's going on. So we do a pre-assessment where we ask for physical health information. So we ask for the physical, so blood pressure, pulse, and then nutritional blood tests where that's possible. We recognise that that's not always possible for young people. Sometimes there might be a needle phobia, sometimes it's just really tricky to get those done, in which case we'll ask for a bit more of a food diary. We also complete something called a PARDI, which stands for PICA, Avoidant Rumination Disorder Interview. So that's a kind of semi-standardised outcome measure questionnaire that's been developed by Rachel Bryant-Moore, who's at the Maudsley, to kind of enable us to have a think about the drivers for the challenges around eating and build a bit more information and understanding for what's going on. So we do that as a pre-assessment, and that's done virtually. And then young people will come and see one of us as clinicians within the team, and we'll spend a bit more time unpicking what's been going on and where they're at. So we always ask to see the child regardless of whether they're only little. We always spend time with them and spend time thinking with them about what's going on. So there's quite a lot that we do kind of before we get to a point where we see a child, because I guess what we know is that for these young people to have the one-to-one time with a clinician in an appointment where we're talking about things that are really tough, we know that that could be really challenging. So part of this is to try and reduce that as much as we can, but to still get the information that we need to really kind of try and unpick what's going on and what's impacting them. So in terms of general tips, so feeding difficulties are usually long-standing. So particularly if we think about the first two drivers, so sensory sensitivities and lack of interest, those generally have been around since weaning. So we're thinking about kind of this 6 to 9 months age, and things have become more challenging as we've introduced more kind of solid foods. So they've been around for a long time. For young people that may have had a choking episode or some kind of trauma around food, it could be a bit more recent. It's really important to avoid force feeding, having long gaps between meals to try to evoke hunger. So some people might say to parents of children that struggle with different foods, if you leave them long enough, they'll eat. If you don't give pudding after that food, they need to eat that, or they don't have pudding, they'll eat. For these young people, that doesn't work. They won't eat. They will stop eating. Likewise, withholding preferred or safe foods. So if you don't offer them, if you don't give those, and the expectation is they eat what you're offering them, then again, that's really difficult. And the likelihood is they would choose not to eat rather than eat those other foods that you've offered. Again, using reward systems for a similar reason, in that children and young people that have ARFID, they're not motivated by food in the same way that other people are. So to use a reward system around food and eating can put more pressure on that. And it's just not necessarily motivational for them. It's really important that children are allowed to eat their safe foods at school. And as a team, we work with schools, and we will often have conversations with schools around children and young people having the opportunity to eat those. Because young people with ARFID, generally, their diet is kind of that typical beige diet. So foods that are maybe more processed. So foods like crisps, chocolate, bread, those things that we might think of as society as an unhealthy diet. That's where sometimes we need to have conversations with school to make sure that those exceptions are made. Be mindful of contamination fears and not enforcing those for those with ARFID. So thinking about kind of foods on a plate. Do the foods, is it easier to just have one food on the plate at a time? Thinking about role modeling. So I'll go on to talk about role modeling, but actually, as a parent, recognizing that this food is safe, therefore I know it's safe, you need to trust me, it's safe for you as well. And that's more when we think about those fear of aversive consequences driver. Really, really, really important, and I will stress this a lot today, is don't overly worry about healthy eating. As long as we know that a child, a young person is physically okay, they're good enough, they continue to grow and develop as they need to, that is really important. And that is our focus within the team. I think that can be incredibly hard. It can be really, really difficult message for people to have, because we're all told all the time about what's healthy, what's unhealthy. And it can be incredibly difficult to know that your child is eating more processed foods, that that's where their diet is. Doesn't necessarily mean that it will be forever, but it's really important that there are exceptions made in order for them to have safe foods, because ultimately it's better that they continue to eat, it's better that they continue to have those foods rather than stopping. So, in terms of tips for managing sensory sensitivity, so during the meal, it can be helpful to reduce sensory stimuli by having a familiar and predictable mealtime routine, allowing the child to eat on their own if they need to, and especially if they seem anxious or overwhelmed. So, it might be not pushing a family meal as much. It might be that, it's okay that they eat separately in the living room while other people eat in the kitchen, or vice versa. Reduce background noise, avoid bright lighting, and create a comfortable and supportive place to sit at meal times. It can be helpful if the dining table is free of clutter, so that there's not too much around in terms of that overwhelm. And like I say, having one food on the plate at a time, sometimes that can also be helpful in terms of our visual system and the information that a young person is taking in. Sometimes we've got there have something heavy on their lap. So what I would say, the reason that we say this sounds a bit strange, but the reason we say this is because of one of our senses called proprioception. Proprioception is knowing where our body is in space, and that is a sense that helps to regulate us. So it helps to move us to that rest digest place. So that's the reasoning behind that. So sometimes, having something like a book on their lap, using, if you've got like a blanket that's a bit heavier, but just draping that over knees, sometimes that can be something that helps just in terms of regulation. Any smells or foods should be introduced gradually, and really gradually. So when I say that, what I mean is that young people it might take them weeks of just tolerating being in the same room as a new food before they can even get to a point where they're able to touch it, or they're able to get any further than that. So anything should be introduced very, very, very gradually. It's important that we avoid any stressful periods if you're doing that, like we would with any change. So, if it's around Christmas, if it's around a new term, moving house, those are the times when changing foods is not going to be beneficial. And if a young person is anxious or overwhelmed at meal times, then gentle distraction can be helpful. So ideally things that aren't too stimulating, but it might be something like having something on the telly or something like that. In terms of managing lack of interest, so routine and structure really is the main kind of our main tip for that. Food and fluid should be offered regularly. So for young people that have a lack of interest driver, as I say, they might not even think to eat and could be quite happy to go all day without eating or drinking. So for some younger children, they would need that kind of prompting from their parents, from caregivers in order to do that. For older children, then external reminders can be helpful. So things like having an alarm on your phone, having a list of something of what you need to be able to manage that day that you tick off when you've had it, things like that. When we say consider the division of responsibility, what we mean by that is that it's a parent's role to offer and prepare the food with an expectation that the child eats it. It's their role to then eat the food and be able to do that. It can be helpful to make mealtimes fun and social, and it's really important to role model, because if as parents, if we don't eat, breakfast, but we're asking our child to do that when they haven't done that before, then that can cause some difficulty. So role modelling, again, is really important in terms of that routine around food and meal times. In terms of managing fear of aversive consequences, again, role modelling, I know this food is safe, it's okay, I'm eating it, and that's okay. Regular exposure to safe and new foods where they're able to do that, and positive feedback and praise. What I would also say in terms of aversive consequences is to try and kind of reduce reassurance around things. So you might find that a child says to you, will this make me sick? Has this been cooked enough? Is this still in date? Kind of those reassurance seeking questions. What happens when we give too much reassurance is that can inadvertently reinforce anxiety. So it's important to kind of try and take a position of it's okay, it's safe, rather than getting into any kind of circular conversations around the reassurance. So, feeding difficulties are usually long-standing, and change and progress may be slow and it could be limited, but changes can be possible with clear expectations and boundaries, consistency in approach, structure, routine, perseverance and commitment, and that would be from everybody within the family or everybody that's involved with that young person, and a motivation to make changes. And motivation, I'll go on to, probably be a bit sick of this word in about 10 minutes, because I'm going to go on to talk about motivation a lot, but it's one of the key parts that is so important when we think about changing food. So in terms of boundaries and role modelling, so like I've already said, it can be helpful to have family rules around eating behaviour. So for example, we all have breakfast. We all do this before we go to work, go to school. And this might mean that as a family, adjustments need to be made by everybody to support changes that are needed for a young person that has ARFID. Within the team, across the whole team, we talk a lot about food being medicine. So it's something that we all need to be able to survive. It's a non-negotiable. It has to happen. We have to eat and drink. We don't have to love the food. We don't have to particularly enjoy the food, but we do have to tolerate it in order for our own well-being and functioning, and in order to do the things that we want to be able to do. Depending on the risk of physical compromise, sometimes we might ask to reduce or limit activities. What I would say is within the ARFID pathway of a team, we try and do that as little as possible. We recognise that for young people with ARFID, they might generally be a bit more anxious. They might generally find change or think being out of their routine more difficult. And so therefore, we will try not to do that unless it's absolutely necessary. Sometimes it is. Sometimes we might need to do things like reduce PE or reduce out of school activities as a first step. It's really important that parents, carers try new things, step out of your own comfort zone and embrace change in a positive manner where you can. That can be really helpful. So again, there's the role modelling of enjoying something and trying something new. So if changes are desired and needed, then there needs to be a change in mindset, attitude and behaviour from everybody. And that's not just for the young person that has ARFID. To be consistent regarding approach or messages between caregivers is absolutely crucial. So around boundaries, expectations, rules. So if one house, if a young person's parents are separated, for example, and on one house on Monday to Friday, they're expected to get up at a certain time, have breakfast every day and manage all their meals, but then they go to somebody else's house at the weekend and that doesn't happen, then that can make things really challenging. Parenting a child with ARFID can absolutely be exhausting. It says here that it's easy to fall into a habit of only offering preferred foods, but actually what I would say to that point is it's also absolutely okay to only offer preferred foods. So what we know, and I said I talk a little bit about motivation, is that For young people that are, particularly I would say young people that we see, the younger ones kind of between 5 and 10, that motivation just isn't there in terms of change. They're not ready to change. They're not ready to think about changing their foods. And actually, if we try and push that when they're not ready to, or when they're too young to do that, what can happen is that can actually kind of cause an adverse impact. So what that can do is make meal times much more stressful for the long term. So it makes things harder. It increases their anxiety and then makes it more difficult for them to change when they're ready to. And quite often we don't see that kind of that motivation coming in until young people kind of hit adolescence. So when there's more of a social motivation, so their peers are doing things that they want to do. They want to be able to go to Pizza Express, or they want to be able to do the things that their friends are doing. And that's where that motivation kind of takes over the anxiety, takes over the fear. Sometimes, though, if a young person does have motivation to change, or physically something needs to change, something needs to be added because we recognise that their physical health is impacted, then there needs to be perseverance and commitment by everybody to persist in making those changes and to do something different. So it might be that something needs to be tried several times a day, every day for a period of weeks or months to be able to make that change. And like I say, that could be just tolerating being in the same room as a food that they don't like, and you might need to do that every day for a few weeks before they can get to a point where actually, okay, I'm ready to poke the food, and then continue that, doing that for a few days over a few weeks before they then get to a point where actually they can pick the food up and smell the food. So it is a process that needs lots and lots of perseverance, which again is why motivation is so important. And change is scary and uncomfortable, and quite often it's not enjoyable. And I think that's something which I know that I can definitely relate to that. Change isn't something that I particularly enjoy. And so for young people, they can lose sight of why that might be necessary or important. So where we can, it's important that people around them, so adult carers, parents, remain positive or hopeful and encouraging. And then here we go, there's that motivation again. So we all need a reason to do or to not do something. So again, all of us on this call will need that. And my motivation is going to be very different to your motivation for doing something. And that's the same. That's the same for young people that have ARFID. You know, their motivational reasons are really different between themselves and their parents. So for example, as a parent, you might be frustrated because you can't find the foods. They've switched, the brand has changed a particular part of their recipe, so that doesn't work anymore. The packaging's changed slightly, so your child's not going to have that. You need to find something completely different. You might be incredibly worried and anxious about your child's health and well-being. So these are the reasons why you might really, really want them to change. Whereas for your child, they're all right, thank you very much. They don't see any of that necessarily. And so they're not necessarily motivating factors for them in order to think about change. And then we talk about kind of push factors or pull factors. So push factors might be things that help us to move away from a position. So for example, my hair's falling out because I'm nutritionally compromised. I don't want that to happen, so I'm motivated to make changes to stop that from happening. And a pull factor is something that moves us towards a position. So I want a boy or a girlfriend and I want to be able to go out for dinner, and I can't do that, so I'm motivated to change. I would say in my experience, this is the pull factor is probably the most frequent reason that I see in terms of young people wanting to change. So as I say, wanting to be able to do the things that their friends do, whether that's going to McDonald's, going to Pizza Express, being able to stay at somebody's house for a sleepover and be able to eat what's offered. So that, in my experience, that's where we see motivation come in much more. And as with any change work, a young person, or we all, need to have internal personal reasons to make change. So for them to be able to engage in the process and for that sustained and significant progress to be made. So we all have to want it. We all have to really have something that's personal to us. That means I want to be able to eat a new food. Okay, and so we should have lots of time for questions, which is good, I think. So in terms of resources, the Hampshire CAMHS website is brilliant. For those of you that haven't looked at it, there's a huge wealth of information on there about eating disorders. There's an e-learning that was done by Dr. Emily David, who started the pathway within our team a few years ago. And there's also information on things like relaxation or mindfulness, things to kind of help with anxiety management strategies. There's also the BEAT website, and I believe there's also a support group that BEAT offers as well for young people, for parents of young people that have a diagnosis of ARFID. The child feeding guide talks in a bit more detail around the steps to eating. So as I've talked about, that kind of graded exposure to eating new foods, and what that might look like in practice. And then in terms of the books, the top one on there, so Food Refusal and Avoidant Eating in Children, I think is a really good resource and really good book. So it talks about the different drivers. It's not particularly jargony, so it's quite straightforward. And I think it's something that you can kind of pick up and take what you want from it, take those strategies. You've also got the Avoidant Restrictive Food Intake Disorder Guide for Parents and Carers, which is written by Rachel Bryant-Waugh, who's kind of done lots of research around ARFID, and is the lead for the service up at the Maudsley, and then Helping Children Develop a Positive Relationship with Food by Jo Cormack. So these are some resources that can also be really helpful to look into. I appreciate we've kind of gone through that super quickly. But I think with the kind of diagnosis that ARFID is, it's quite tricky to talk about the specific ins and outs and to kind of give real, I suppose, specific advice and recommendations more than we have, because the drivers and the context for the eating difficulties are so different and so varied from person to person. But hopefully, we've got space now for questions and discussion. So please do ask any questions that maybe you'd like a bit more information on.
Thank you so much, Nicola. Yes, there's questions that are coming through the chat box. I'll let you have a sip and then I'll start reading them out to you. 100%. Right. Some of these may have actually already been answered through. So if they have, then we can move on. So my son shocked eating apple 3 weeks ago. Since that episode, he is extremely scared to eat any kind of solid foods, just drinks yogurts and smoothies, and his anxiety is increasing, and he's starting to have tummy pains and is reducing the liquid food.
Okay.
We're waiting for an appointment, but what would be your advice in this situation right now?
Okay. So it sounds like he choked on an apple, if that's right. So what I would say, I would assume that you've had contact with your GP. It's really important, and I appreciate this is difficult. It's really important that you try not to reduce his intake as much as possible. So keep going with that. What we don't want to happen is for this kind of avoidance to come in. So the avoidance and liquid food to then come out as well, because what can happen is then that reinforces the fear. So wherever possible, absolutely keep going with that liquid food. See your GP. I would say you probably need to be seen fairly regularly in terms of that reduction, and keep an eye on physical health and observations. But the main thing is to keep the intake up. If you are concerned, so our advice is if a young person completely stops eating, so stops having all of the intake that he's accepting for 48 hours, to go to A&E. If it's 24 hours fluid refusal, go to A&E. So that's kind of our general safety information that we would advise people to do. But keep going and absolutely speak to your GP and make a referral to, if you're within Hampshire, referral to be seen with us.
Yeah, I believe they're waiting for an appointment with yourselves as well.
Okay.
That's
Okay.
yeah.
So if things have changed since you've been on our waiting list, please give us a call and on our duty number. So on our phone number, there's always someone on duty Monday to Friday, 9 to 5. So if things have changed and intake has reduced and you're really worried, please do give us a call and we'll review where you're at.
Thank you. I believe this was covered actually, but I'll read it just in case. Is the diagnostic eligibility criteria strictly weight loss, not gain? My ASC son is overweight as the only foods he eats are carbs, high fats and sugars. Yeah.
So I think it it isn't. But I guess what we would think about is a nutritional deficiency in that case or psychosocial impact. So very generally it isn't. I think I think that there's sometimes for some young people that maybe are overweight, there might be other services that are a little bit better suited. So, like an obesity service, for example, that is also kind of can be a really specialist feeding clinic too. So that doesn't being overweight doesn't kind of rule out ARFID, but it might mean that we think about other factors alongside that. Hopefully that makes sense.
Thank you. So this one, 2 queries. Is the underweight based on BMI? My son has dropped percentile, but still just sits within norm.
Mhm.
And then the second query is, are blood tests the only way to show nutritional deficiency?
Okay. So, in answer to your first query, no, underweight is not the only thing, and we do think about dropping centiles as well. In answer to second query, no. So what we do, wherever possible, in an ideal world, we would like blood tests and we'd like full nutritional bloods for young people that come through to us. We recognise that we can't do that always for whatever reason. So what we do is we always ask for a food diary. So at the moment if we've got bloods, we'll ask for a 3-day food diary. If we don't have blood tests, then we'll ask for a longer period of food diary, so a 5 to 7 day food diary. And then we have our dietitians in the team that are really supportive in terms of thinking about nutritional deficiencies. And we've also got some software that we use to analyse that food diary to think about where we might consider a young person could be deficient in vitamins and minerals.
Thank you. My son is 11, but only heard about ARFID last year. He's always had trouble around food and it has always affected family life, but finding it hard to get any help. He's been seen by feeding teams in the past here and in Essex, but was told his weight is normal, can't do much more. Where do I go from here?
Okay. So I don't know if it was a feeding team that whether you were seen by us or not. I suppose what I would say is, so what we would need to think about if your son came for an assessment is we'd think about the psychosocial impact. So the question would be actually if nutrition's okay, physical health's okay, then actually is psychosocial impact enough that we would think is that significant? So it's impacting on kind of those normal developmental norms. That's rubbish language, but you know what I mean, hopefully. So that's what we would be considering. What I would say is I think within cases where physical health are okay, it can be a bit more challenging to think about what next or what help might be available. The reason for that is part of also what I was saying about motivation. So it might be that your son, does have real challenges with food, is anxious around different foods, but actually at this point in time isn't ready to change that. And so physically is okay. So in which case it's thinking about, say, A, would the diagnosis be met through a psychosocial impact? And B, if that is met, then actually would we at that point offer any further intervention?
Thank you so much. I think this one refers back to when you were talking about treatment or the process through CAMHS itself. How does it work if a child cannot leave home?
We do offer, we would offer some home visits, so we can do that. I think what I would say, so ideally we would rather that young people come to us and see us in clinic, but you know, we know that that can be really tough. I suppose what we would also need to think about, I don't know the reasons why they can't leave the house, but think about what the reasoning is for that. And actually, is it more that, you know, if it's an anxiety-based challenge, is it more that actually they need support from our community CAMHS colleagues before we think about the food and eating? Actually, is the anxiety generally more of a priority than the food and eating? But yes, we can do home visits if absolutely necessary.
Thank you. So this one, in terms of not worrying about healthy eating, is it safe for our children to keep eating such a reduced diet and higher sugar foods long term into adulthood? After discharge from CAMHS due to reaching a healthy weight, is there any ongoing support to encourage exploring new foods, expanding the diet in the long term due to ongoing significant restriction in food intake?
Mhm. So what I would say, I don't know when you were discharged from us. I think it is a balance around whether we try and push healthy foods now when a young person isn't motivated to do that, because the risk of pushing that is that actually we make things much harder, we increase stress, we increase anxiety, and we make things worse. So actually, I think what we try and do within the team is we try and safeguard their physical health. So we are thinking about those nutritional deficiencies at this point, and their obviously their weight as well. So we do consider that. What I would say in terms of ongoing support, the websites that I talked about at the end are very good. Thinking about the Beat website. The other thing is that within our pathway now, we've changed things slightly. So we offer a parent workshop, and we will also be offering some skills-based sessions for young people that are finding it more challenging, where there's a specific need to change. So that's information and advice that parents can then take forward to do at home. Unfortunately, the change of the foods happens at home because it's something that needs to happen every day consistently for weeks. So that, you know, it is something that needs to happen there rather than in a clinic space.
Thank you. What if there are no signs of motivation to change in a 15-year-old? Oh my gosh, yeah.
Yeah.
Anxiety is so high, just even
Yeah.
discussing to try something new is
Wow.
tricky. Yeah,
Yeah. Yeah.
teenagers.
That's really
Yeah,
tough.
yeah.
Is really tough, and I think I suppose it can come in at any time for any one of us. I think I was just thinking, you know, 15, you've got coming up to kind of that last year at school, GCSEs coming up, maybe stress and anxiety is a bit higher generally anyway. I think it's important to keep the doors open. It's important to kind of maybe have conversations or open conversations around food and around where they're at, but also recognizing that maybe that motivation isn't there, and perhaps to keep talking about it, it might kind of increase that shutdown response, I suppose. So it's hard, but it might be worth taking a bit of a step back and then coming back to it, or thinking about it, you know, depending on when you have the conversations. It might be that you have a conversation when there's something else going on. Sometimes it can be helpful to have a chat when you're on a journey somewhere and you're in the car, so you're not just focusing on we're having this conversation, but while something else is happening, could be a bit easier, particularly with adolescents.
Yeah, I always find the best conversations with my own daughter is the organic ones, the ones that just pop
Yeah.
up out of nowhere. And when she's really regulated, that's sometimes where some our best decisions and conversations about moving forward.
Yeah, yeah. And I would also say go
Yeah,
with the interest. So if the interest starts in terms of, you know, if your child sees something that you're having and thinks, oh, that looks okay, or that doesn't smell too bad, go with that. So be led by them. Because the more that you push and you put on them, the more that those barriers will come down.
thank you. Lady here said she identifies with quite a lot of this herself. Where can she actually get support herself as an adult? And I would say those resources you put up, there's no age limit on the information.
No, 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 no. What I would say, so where ARFID, so there's a couple of bits actually that's probably helpful to say at this point. With ARFID, there's no nice guidelines on ARFID as a diagnosis. So in terms of the evidence base for ARFID as a diagnosis, that's also very limited. So there's some evidence around anxiety, there's evidence around sensory-based strategies, but ARFID as a diagnosis, there isn't. So that's also why it's quite tricky sometimes for services to kind of find the way through of what's the best treatment for these young people in terms of the offer. So that's one thing that I should just add in. The other thing is that, again, because although ARFID's been around for 10 years, it still feels really new. So commissioning across the country can be a bit patchy. So we obviously have our ARFID pathway within Hampshire. I think they're starting to develop one in Sussex, and they're starting to develop more of one in Surrey. In terms of children's, children's pathway, adult services for ARFID is a little patchier still. So it's coming, and there is more development. I know within Hampshire there isn't an adult service for ARFID. Hopefully that might come in the future. We don't know, but at the moment that's where it's at. But I would say yes, that there are much more resources now on the internet, and those books actually are really good. So the first one is a good one to start to go to.
I'd probably say it's not too dissimilar to PDA, where it's not really recognised in this country, but
Yeah.
I can recognise traits of PDA in my children, so I still go out and seek that information. I don't need for somebody to tell me they're PDA, but I do use those strategies that are actually in those books, and those websites, and those organisations that do know a bit more about it.
Yeah,
I would say. I just wanted to ask, how to differentiate between ARFID and ASC sensitivities. Would the ARFID pathway cover this?
It's hard, to be honest. It takes a lot, and that's why in terms of once we've assessed a young person, we always discuss as an MDT. So it's never one clinician's decision on what happens. We talk about, so we make sure that we try and kind of come to the right conclusion as best we can. I think what we would look at is we would think about whether a physical health is impacted by the eating, because as I said, we do expect there to be some difficulties with food and eating with an autism diagnosis. And again, it's a spectrum, and I think we could think of ARFID as a bit of a spectrum actually. So for some people they're going to hit some parts, and for others they aren't. So it's difficult, and we would kind of go back to physical health. But it's a lot. I think there's probably a lot of discussion that goes along behind the scenes between clinicians around what's best, and also I guess thinking about ethically what's right for the child or young person as well. How beneficial would this diagnosis be alongside something else? So we think about all these things.
Thank you. I'm going to keep rolling through these questions while we've got you, if that's okay, Nicola, because this is where the richness comes from. What is deemed a significant weight loss? And what are the side effects of not eating? Could it be cold hands and dizziness?
Yes. It's hard to say. So I don't know that I can give you a specific answer in terms of what's deemed as significant weight loss. What we use, so we use the MEAD guidelines. So that's this acronym stands for Medical Emergencies in Eating Disorders. So that's a risk assessment that clinicians use, so paediatricians and clinicians use, and we use that within the eating disorders team. And that kind of gives us an idea around who's at physical risk. So generally we might think of a young person. So we talk about a weight for height percentage rather than BMI, because weight for height is a bit more specific for young people. So generally we might say, somebody's healthy if they're between 95% and 105% weight for height. But that's different for everybody, particularly young people that are diagnosed with ARFID. They may have been chronically underweight for a long period of time, or they may have always been lower on their centiles. So that information is what we would consider and we would take into our assessment. So it might be that we see a young person that actually comes to us, they're about 80% weight for height, and we say, actually, we think 85 is probably where you need to get to. We don't need to go that way. Within girls, a really good indicator is whether or not they're having their periods, if they're old enough to start their periods, because that's kind of our body's way of saying that we're okay. It's one of the first things to stop if our body isn't healthy, and it safeguards our kind of bone health as well. So periods is something to look out for. But yes, you can have increased so coldness in your extremities, dizziness, or increased dizziness, fainting. What I would also say is sometimes those things can also be an indicator of a nutritional deficiency. So it might not be that there's a weight difficulty, but the nutritional deficiency. So I'm thinking about iron, for example.
Thank you. This lady, they had a breakthrough. Yay, nibbled the outside of a pizza and a chicken nugget, which they haven't touched for 2 years, but now have no interest again. They're aged
How
4. Is
frustrating.
this quite usual?
Yeah, absolutely. And that is amazing that you had that. And I think go with it. You've got it. You've got that once. I think try again. Like I said, I would say try not to push it. It absolutely is usual. If we think about, you know, food and eating is so inherently impacted by everything else that's going on around us. So our day, our stress levels. Is a child been at school all day and actually that's a difficult place, or they've been doing lessons that they really don't like, or around people that they're not keen on, whatever, you know, it's going to change, motivation's going to change, interest is going to change day to day. So absolutely, that's normal, it's okay, and just go with it. And if your child is interested in doing it again, go for it. Because I think that's really important that you've had that. It's really positive.
Sorry, I was just replying to somebody. Why do some areas of Hampshire diagnose and others prefer not to?
So all of Hampshire diagnose, because it would all come under Hampshire CAMHS. Yeah, we do. I don't know if it might be slightly different if you're under kind of Solent in terms of the Southampton City, Portsmouth City. But yeah, Hampshire diagnosis is through Hampshire CAMHS.
Okay. Thank you so much for this information. I found it hugely reassuring that my understanding and approach has been correct. Sometimes that's what we need as grown-ups.
Yeah.
And that my daughter may simply just need a little bit more time to find her own motivation to enable her to try more foods, which has slowly started to happen. Do you know, I was sat here thinking, my friend, they didn't have the name ARFID back in the day when we were younger, but now we're eating partners. Shame for our weight, but we are eating partners because she had the motivation to change when she went to university.
Yeah,
and she was
it's
around.
so important because it's stressful and it's so personal and it's so within our own control. And you know, if you're being asked to do something day in, day out for a long period of time and you have no motivation to do that, you are going to feel rubbish. We're setting you up to fail, aside from it. So it's just going to impact on your self-esteem, it's going to impact on your anxiety levels, your stress. It's so important.
Okay, I'm just whizzing down some of the questions because some of them have actually already been answered, so I'm just going to pass those. So my son is autistic and he's not drinking any juices and not eating fruit other than apple. He's eating apple. Fantastic.
Yeah. That's okay.
Not everybody in CAMHS will know about ARFID. That there's different sections of specialisms.
Yeah.
Would that be correct to say?
Yeah.
Yeah.
I would say that it's sorry, we've got the kettle on, so sorry if you've if you lost me. What I would say is that it does it's definitely becoming more well known across CAMHS. I think it's taking time, but absolutely we're having more kind of consultation with our colleagues in CAMHS to think about ARFID and to also think about, you know, who's best placed to support young people in this, because you know, for a young person that maybe they have a real kind of challenge around anxiety, it might be that we need to think about that first before we even think about the food. So I would say it's definitely getting better, but there's still a way to go.
Okay. We use Abidec to help with vitamins for our 8-year-old son. Are there any more comprehensive multivitamins, mineral supplements?
I'm probably not the best person to answer that. But what I would say is there's still so there's things like the Vitamix sprinkles that are quite good that we would think about. So they're things that you can add to fluid or you can add to food that should be flavourless or without texture. There's the sprays as well. But generally, as long as a child is having an A to Z multivitamin, then that's got everything they need in it.
Thank you. I've got about 3 more questions. Is that okay, Nicola? Can I keep you on. Hypnotherapy is said to work sometimes. Is this offered under CAMHS, and does it work for younger kids?
No, so it's not offered under CAMHS. I know that it's something that's become more prevalent as a treatment. I think the evidence base behind that, as there is with ARFID, the evidence behind that is limited. So I can't say whether it works or not. It depends on the person and depends on their circumstance. But no, it's not offered through CAMHS, and there's no plans for us to offer that.
Okay. Thank you so much, Nicola. Guys, if I haven't answered the questions, please, you're going to get sent the recording link. So go back over the recording and over the notes as well. There, your question might have been answered further back in the talk, but I'm going to stop recording now, she says.